Hi guys, this lecture is going to be over Chapter 4, Injury, Pathology, and Nomenclature. Absolutely an important and integral part of who you are as a healthcare professional is your ability to communicate consistently with other healthcare practitioners as well as practitioners within your actual practice. So a standard approach to describing the body and its conditions really is essential, right, for you to be successful as a healthcare practitioner. Use of standardized terminology is increasingly important, specifically with the change in healthcare and the new regulation and requirement for most healthcare practitioners to actually do medical charting in the online setting. In other words, now you're typing into a computer, and this computer and the program can be shared amongst healthcare practitioners. Well, wouldn't you be frustrated if you picked up a medical chart and you couldn't interpret what another healthcare professional wrote, right? And so it just becomes even more important as we're moving away from paper documentation and we're moving to online documentation. Most importantly, I think the use of a standardized language really improves the validity and reliability of healthcare in general. So with that being said, we're going to spend the first part of this lecture really just talking about terms. Some of you may know these, some of you may not. We have a huge disparity in the type of student in this class. We have pre-physician assistant, pre-physical therapy. We have athletic training majors who are only sophomores. So we really have to start at the base and build the foundation. So if this is a review for you, listen as much as you'd like to, but if it's not, I'm holding you accountable to the content that is in this online lecture. So the first thing that we want to do is we really want to start with anatomical terms. The first thing that we want to do is really just look at the human body. What you will see in this slide is, number one, that this patient is in what we call the anatomical position. What is the anatomical position? It is a patient standing upright. And if that patient is facing you, what you will see is those hands are facing forward, are in a supinated or supinated position. So this is the anatomical position. Patient is upright, patient is facing you, and the hands are turned into a supinated position. And then you also see that the feet are facing forward. From there, we can describe cardinal planes. We can also describe directions, which we'll talk about in just a second. So let's start with our cardinal planes. There are 3 cardinal planes, and each of these cardinal planes kind of bisect the body into different sections. The first plane that we'll talk about is the sagittal plane. The sagittal plane bisects the body into right and left halves. And what you can see is that with this bisection, what we tend to see and what we describe movement-wise is that flexion and extension occur in the sagittal plane of motion. So at the hip, that'd be hip flexion, extension, knee extension, and at the ankle, we would call it dorsiflexion, plantar flexion. Our next plane that we have is the coronal plane or the frontal plane. The frontal plane or coronal plane bisects the body into anterior and posterior halves. What we see with this most often is that motion that occurs in the coronal or frontal plane generally occurs in a abduction, movement away from the midline, and a deduction, movement back towards the midline. At the hip, same thing, hip abduction, a deduction. At the knee, described a bit different as valgus and varus, and then at the ankle it would be calcaneal adduction and calcaneal abduction. Our last plane is the transverse plane. The transverse plane kind of bisects bodies into upper and lower half, and this is probably the plane where most of the motion in the human body occurs because it is a plane that involves multiple movements. In other words, it is a rotary plane. It's where rotation occurs about the axis. So what we'll see in the transverse plane is at the hip is internal, external rotation. At the knee, we would call it either distal femoral internal rotation and external rotation or tibial internal external rotation. And at the foot, that combination would be known as supination and pronation of the ankle joint itself. So now that we've kind of reviewed the 3 planes, cardinal planes of motion, let us go into a description of anatomical terms. And again, for some of you, this may absolutely be a review, but I'll be quite honest in admitting that sometimes I forget what these terms mean, or I sometimes misuse them. So we'll start with the terms superior and inferior. When we think about superior, what we're saying basically is we're using this term to refer to something that is above something. And then when we are using the term inferior, what we're using it for is to describe something that is below another anatomical structure, right? And so in the anatomical position, the most superior part of the human body obviously is the head, right? And then the most inferior part of the body are the feet, right? And so most superior part would be the head, most inferior part would be the feet. We describe something as anterior, what we're describing it as, what we would basically say is that it is towards the front of the body. We describe something that is posterior, what we are saying is that it's something that is towards the back of the body. When we describe something that is proximal, what we would say it's nearer to the origination of a structure. And when we describe something that's distal, what we would say is it's further away from the origination of a structure. Superficial, as it probably implies, means that it's close to the surface of the body. And then if we were to describe something as deep, what we would say is that it is something that is away from the surface of the body. We think about medial and lateral. I'm going to go back to this image here. When we think about something that's medial, what we are saying is that it's something that's closest to the midline of the body, right? And when we describe something that's lateral, what we would say is it's something that's furthest away from the body. So that's why it becomes very important, at least when we're assessing the wrist and the hand, to make sure that the patient is in an anatomical position, because again, this part of the hand would be more medial, and then obviously this part of the hand would be more lateral. So medial means something that's closest to the midline, and then lateral means something that's furthest away from the midline. So our last anatomical terms will be cephalad and caudad. And when we think about these terms, they're very similar to superior and inferior in that cephalad means towards the cranium instead of the head, which is a fancy way for saying head, and then caudad would be towards the feet. So superior, inferior, cephalad, caudad, very similar in terms of anatomical directional terms. So with that being said, we've kind of described the anatomical position, we've described the cardinal planes, and we've described kind of directional terms. Now what I kind of want to do is really start talking about the tissue's response to stress now that we've kind of have these terms. And so one of the questions that I always pose is, how much can our body actually withstand, right? How much stress can the body withstand? What we see is that the tissues that form the human body really are reactive in nature. In other words, they react to the force and the stress that we are applying to them, right? And for the most part, they behave in a predictable manner. And so we kind of have to look at this image right here, right? Because to me, this image really describes what our tissue's response is to the stressors that we apply on it. And what we can see from this is that this represents the physical stress level that's being applied and what happens as the stressors are increased across the body. So what we have really are two ends of the spectrum. On one end, what we have is one undesirable response, which would be atrophy or muscle wasting or the muscle getting smaller and not being as forceful. And then on the other end of the spectrum, we also have another undesirable response, which would be injury. So when we look at this kind of stress-strain curve, what we're kind of looking at is how much stress needs to be applied to the human body really to either just get it back to its normative state, its healthy state, or to even do more than that, to increase the strength of either the muscle or the unit that you are actually working on. Ideally, what we want as clinicians is we want this right here. We either want our patient to get back to healthy, or we want them to be better and above where they were before they first came to see us. And so what does this describe? When we think about stress, it's this broad and encompassing kind of definition that is really used to describe physical forces that are applied to the body, right? And so when we think about these physical forces, we really have to keep this in mind as clinicians, because if we apply too little force to the body in an injured patient, then that patient doesn't get better, that muscle doesn't get stronger. In fact, what we see is that we actually have muscle wasting occur. So if we are the type of clinician who isn't really doing a whole bunch with our patients, we're not going to be challenging that unhealthy tissue, and that unhealthy tissue really isn't going to get better, right? And that's where we get to this idea that some stress is needed for soft tissue and bone to maintain homeostasis, right? That level of activity varies from person to person, but as long as the stressors are applied to the body and they stay within this range right here, then there are no physiological changes that occur, right? When the relative level of applied stress falls below homeostasis, then that's where we kind of get this atrophy that occurs. And we can see this most often in patients who have been immobilized in either a cast for a relatively long time or a walking booth. And what we tend to see, right, is the girth of those muscles actually decrease or become significantly less than the healthy limb. And so that's why I say it's undesirable, because what you have is you have this unhealthy tissue that's not strong. And the reality is, if we place that patient back into activity, then they're probably going to be set up for injury all over again, right? So what do we want? What's ideal? What we want to do is apply enough stress so that at least we're maintaining homeostasis. And if nothing else, if the stress is increased and it's applied to the body in a progressively increasing rate, then what we can also see is that maybe we might have some hypertrophy that occurs. In other words, what we get is this increase in muscle mass and this ability of that connective tissue to withstand the forces. And ideally what we have is a patient who doesn't get injured because they have a strong enough connective tissue or tissue to support the desired demands for that particular body. On the opposite end of that spectrum, what we don't want to do is apply too much stress to the body. Because if we apply too much stress to the body or the joint or the muscle, then we get the other undesirable response, which is that tissue kind of can no longer withstand the stresses, and that tissue either ruptures, it becomes strained, right? It becomes injured, that bone fractures, and we have injury. So what am I saying? What I'm saying is this, is that when we apply stress to the body, we need to apply enough stress to create change or to at least maintain homeostasis. If that stress is less than what is desired by the body, then we get atrophy that occurs. If that stress is too much and the tissue cannot withstand it, then we kind of have an injury that occurs. So be the clinician that works within this range. And well, you might say, well, how do you know if you're doing too much or you're doing too little? Well, the signs would be pain, the patient's inability to continue with the rehab or the treatment, right? And then on the opposite end of that, in your objective measurements, when you maybe are measuring girth or strength, you would see a decrease in both of those measurements. So those are just different signs that you as a clinician could look at. So we've talked about stressors, right? In the next slide, what we're really talking about here are the different types of mechanisms of injuries that can occur to the human body. And so what we're saying is that we have to be able to identify the mechanism of injury, right? And we do this through the history taking process, which you will become good at in this class. And so one of the things that we kind of see really are two different things. Really what we have is either macro traumas occurring and or micro traumas occurring to the body, right? And we think about macro trauma, what we're really saying is that the injury occurred when a single force exceeded that failure point, right? In other words, if we go back to the slide, we were applying way too much stress to the body. And as a result, one single force, because of that massive stress, caused injury to the human body, right? The opposite end of that spectrum, remember here, we could have lots of what we call micro traumas building up, micro trauma after micro trauma. In other words, repeated submaximal forces occurring over time. And as a result, those micro traumas continue to build up, and what we get is failure as well. So we can have really two injury types. Really, we can have something that was acute and traumatic and macro traumatic in nature, or we can have repeated bouts of chronic injuries that occur that build up to cause injury as well. So when we look at this particular image, we're really looking at our tensile forces. And so we kind of want to look at what are the stress and strain relationships, how much load can be applied, and how much deformation can our tissue actually go through before it reaches its failure point. So the stress strain curve that we see here really kind of just is a descriptive of the amount of tension or load that a specific tissue can kind of tolerate, right? And so what we see with tissue, let's just imagine that we're stretching a hamstring, right? So kind of imagine that. And so what we kind of see is as we move that foot off the table and as we start to kind of flex that hip, we're kind of in the toe region of the tissue. In other words, it's the early stages of tissue development. It's where we're really starting to kind of just take the slack off of the actual resting tissue, right? So the tissue slack is being taken up. And really, honestly, in the early stages of stretching, there's relatively little change in the patient's strength or the load of that particular tissue. But it's as we begin to continue to move that hip into flexion that we can kind of imagine now that we're starting to get this elongation, right, of the muscle. And once we hit that stopping point almost, right, we're in the elastic region or the end phase of the elastic region of the stretch. It's when we go past that point of tension or stiffness that we kind of go into this plastic region. And that's kind of where we have to be careful. When we go into a plastic region, that's awesome. That's great. What we see is that we're in this point of stiffness and we're taking that muscle past the point of stiffness. And what we see in this plastic region is that a lot of the permanent changes in flexibility can occur. One of the scariest things about being in the plastic region, however, is that we're past that point of tension. We're a little bit more into the strain side, is that if we apply too much stress in the plastic region, we can actually cause injury. So it becomes very important when we're stretching our patients that we keep that in mind. We're lifting the foot off the table, and then here we're kind of taking up the slack. We get that nice stretch. And if the goal isn't to increase flexibility, if it's not to increase flexibility permanently, then we kind of stay in this region. But if the goal truly is to kind of permanently improve flexibility, then we kind of have to take it past the point of stretch and into the point of strain. One thing that I always like to say, maybe to drive this home visually, is to kind of think about a rubber band. When you pick up a rubber band, it's kind of coiled a little bit, and then as you put two fingers in the rubber band and you stretch it out, well, that's our toe region, right? The band is kind of coiled, and then as we stretch it out with our two fingers, now we're leaving the toe phase, we're taking up the slack. As we stretch that rubber band and we open up those two fingers, we're in the elastic phase. And there will be a point in time in the rubber band where you will start to see the whiteness of the rubber band or the stretching of the rubber band. And so that's when we're in the plastic phase. What I say is if we take it too far, that rubber band snaps, and that's where we hit toe point PC, where we actually have injury. So I hope that visual kind of drives it home for you. So let's look at a few examples, right? What we have here is a load deformation curve, and they're often used to help us kind of understand the properties of tissue better. So in this graph, what you have is the load being plotted on the y-axis, and then you have the deformation being plotted on the x-axis. And so what we kind of can see is that the point at which the curve begins to bend, right in there, is the point at which permanent damage can be sustained in the tissue. So prior to these points, right, prior to this point here, point B there, and then point C here, what we can kind of see is that the tissue is said to be elastic. So right now we're in this elastic phase of the tissue, and we can see that each of these tissues kind of have different elasticity, right? Can you guys see that? And so what we kind of want to kind of look at here is what is exactly how much load, right, can be applied before the tissue reaches its breaking point, okay? And so would it help you to know that, okay, this is ligament, this is tendon, and A is muscle, right? What we can see is that for A, the deformation occurs at about 5 centimeters before suffering from injury. We can see for ligament B that the deformation occurs at about 3.5 centimeters, and then what we can see for tendon C that it occurs at approximately 9 centimeters before suffering damage. Therefore, what we can say is that tissue C is really the most extensible in a sense, because it can deform or go through more deformation, if that makes sense. We can also see from this graph is that the amount of load it takes to reach its plastic phase, right? So we can see for tissue A, the amount of load is approximately 20. And then what we can see for ligament B and tendon C is that that load is around 15. So it can withstand less load than maybe the muscle, but ultimately the tendon is able to be deformed more, right? This becomes important when we're thinking about how we treat our patients, how much load we should be applying to specific anatomical structure. So this is just an example of looking at, okay, how much load can be applied and how much deformation can occur in that tissue before we really hit the breaking point in that tissue. So we think about the rate of loading. What we know about bone is that it's stiffer. Obviously, it sustains a higher load to failure, and bones were built that way, right? They were built to withstand a lot of stress. Our muscles and our tendons and our ligaments, not so much, right? And so it would make sense that bone is going to be stiffer, and when you compare it to other soft tissue structures. So when we look at the rate of deformation for a bone, I kind of wanted to look at like walking versus running versus maybe jogging, and just to give you, okay, this is the amount of stress and this is the amount of strain. And so what you can see is that obviously as we increase the rate at which we walk, then obviously more stress is going to be applied to the bone, and you're going to probably have a little bit more strain being applied. Okay, different types of forces. There are several different types of forces that can occur in the body. Since we are in a lower extremity class, I wanted to focus solely in on the lower extremity, but please know that these forces can be applied to the upper extremity. The first force that we have is a tensile force. A tensile force exerts a longitudinal kind of tearing stress on a structure. So such as like when you put a weight on a rope and then you drop that weight from a tall building while holding it, right? It's almost like the bungee jumping kind of sort of thing. And when we think about tensile force, what we're going to say is that it's going to be basically kind of opening up or causing an opening up of the joint. And then on the other side of the spectrum, we have a compressive force that can occur. So in other words, those two bones or that joint butts up against one another, right? So in other words, compressive forces result when stresses are applied at the end of the structure. And so what we tend to see most often is that when you have a tensile force injury, a stretching of a structure on one side, what you tend to see is a compressive injury on the other side of that joint. I'll give you the example of the ankle, even though we're looking at the knee. When you have an inversion ankle sprain, in other words, when your foot rolls in, the tensile force injury is all of the stretching that occurs to the lateral side of the ankle. But would it surprise you to know that 50% of injuries that occur to the ankle actually happen on the medial side? Because what happens is as the foot moves in or is planted and is rolled in, the medial calcaneus butts up against the medial malleolus, and it creates a compression injury on that deltoid ligament on the medial side. So most often what we see is that when you do have a tensile force type of injury, a stretching-like injury, you also can see a compressive force injury on the opposite side of that particular joint if it occurs to a joint. The next type of force that we have at the joints, what we call a shear force. Shear forces occur perpendicularly across the long axis of a structure. So when a shear force is of sufficient magnitude and it's applied across a bone, you can get basically what we call a transverse fracturing. So you can get some type of fracturing right in here. Obviously with a shearing force, right, where one bone maybe is going in one direction and the other is going in the opposite. You can also get other injuries that occur. So you can get ligamentous damage, you can get muscular damage as well. It really just depends on the actual joint itself. And then last but not least, what we have is what we call a rotational or torsion force. And this usually occurs with some type of twisting motion, right? Such as, let's say, the foot is fixed and then you go to rotate and you have knee rotation that occurs during that change of motion, right? And that's almost like the point of no return, where you get this fixed foot, this rotational force about the knee. You could have an ACL or a PCL rupture occur. It just depends on the direction of the force being applied. With that being said, we've talked about the type of forces. We said there's tensile force, which is stretching force. We've said there's compressive forces, which is when two joints kind of butt up against one another. We've got shear forces, where you have shear gliding across a joint. And then last but not least, we have a rotational force, where there's rotation involved in that injury. Usually a joint is fixed and then rotation occurs. Last but not least, it's not listed on here, but I guess I'll just say that you can also have a direct blow force, right? So something that occurs directly as a result of a macro trauma. So those are the major types of forces that can occur at the actual knee joint or any joint in the body. So up until this point, we have talked about the anatomical position, the cardinal planes, different types of terms. We've talked about stress versus strain. And now what we're going to talk about is components during injury classification. First thing we have to do is we really have to be able to classify an injury, right? When we do this, there are specific things that we should include in the classification of the injury. The first thing that we should include is the periodicity of the injury. Was it rapid or was it chronic? In other words, was it a macro trauma or was it a micro trauma? This kind of will help form the history questions that you ask your patient. The second thing is we have to look at the integumentary system. Is the skin, right, exposed or unexposed? Is there a complete through and through compound fracture, right? Want to know that. So number one, periodicity. Is it acute macro or is it chronic micro? Is the skin compromised? And then what we also want to do is look at the severity of the injury, right? There are 3 different grades for severity of the injury, and it's very specific to, muscle strain versus sprain. But overall, in general, we describe these terms as either mild, moderate, and severe. Now, for an athletic trainer, if it's anything above a first-degree injury, the recommendation is to refer. But some of you are going to be physicians, right? Some of you are going to be physician's assistants, in which case, obviously, you wouldn't refer a mild injury. You would be assessing that mild injury. And then last but not least, what we want to really look at is whether or not there's structural defect. In other words, when we're palpating our patients, do we note any deformities in the tissue, in the bone, etc.? So when we classify injury, we really want to consider these 4 different components when we're classifying. Is it acute? Is it chronic? Is the skin exposed or not exposed? Is it mild? Is it moderate? Or is it severe? We'll define this a little bit more later in detail. And then last but not least, is there a structural defect? Of course, if there is, then we're referring out, right? If not, then we continue on with our assessment. So this brings us to the bulk of this lecture, and this is all about pathology nomenclature. And remember, the one thing that I said is that we have to be on the same page when we're describing an injury. My expectation on an exam is that you would describe it using the nomenclature and not layman's terms after this lecture. So the first type of nomenclature that we're going to talk about, or group of nomenclature that we're going to talk about, are musculotendinous injuries. Okay, we think about musculotendinous injuries. It's muscle injury, can be related to overexertion or direct injury to a tissue. And so we're going to talk about injuries to a muscle belly or tendon because they can adversely affect the muscle's ability to generate and to sustain tension within a muscle. So a musculotendinous unit has been mechanically altered through tears, then what we see is that this muscle can no longer produce force. So when we look at a musculotendinous unit, what we say is that it's a group formed by a muscle and its tendon. And the most common musculotendinous unit in the lower extremity would be this musculotendinous unit here. And so we have the gastrocs, and then we have basically the Achilles tendon kind of unit. And so what we can kind of see with this musculoskeletal unit or tendinous unit is that it can be very weak, because what we see is that the muscle itself becomes a tendon. And it's at this point in the transition where you kind of worry about weakness, right? Because that muscle is changing its shape and it's becoming more tendinous. And so when we tend to see injuries to a musculotendinous unit, it tends to be where the muscle actually becomes a tendon. Again, as I said on the other slide, what we're really concerned about is these muscle tears or tendon tears that occur within the musculotendinous unit, because again, can really affect the muscle's ability to generate or sustain tension, or the ability for that muscle to generate a force, whether it be secondary to pain, whether it be secondary to the amount of muscle fibers that have actually been ruptured. Okay, and so what you'll see down here, this video will play, is basically the injury that happened to Kobe Bryant. And what you'll see is he'll come up, and this is where he actually ruptures his Achilles tendon. Most of you probably remember this. It was huge, right? He gets up from the injury, and he's able to play. One of the awesome things about injury to a musculotendinous unit is that if one component of that musculotendinous unit is injured, the other component is still intact. So you still have the ability, right, to participate. Again, he came back and he participated, but not to the same strength or to the same level, right? So he's running, he's doing all he can do, just can't generate as much force or sustain the amount of tension, right? So he's walking, he's functional, but just not as functional as he would have been if the musculotendinous unit was intact. Okay, so moving forward, let us talk about strains. I think we all know enough about strains, right? So I'm not going to bore you with the details of a strain. Please know that a strain occurs to a muscle, not a ligament, number one. Strains can be caused by contact, usually is non-contact overstretching, right? Or what we would say would be tensile forces, a stressing force on a specific muscle belly. And then the last way we see this is dynamic overload. Interestingly enough, what we see with muscle strains is that it generally occurs during eccentric muscle contraction. In other words, the contractional phase of the muscle, where the muscle is actually in an elongated position. And that would make sense, right? If you're in an elongated position, you have these tensile forces. Well, if we get past that elastic phase, we're into that plastic phase and we overload, then injury is bound to occur. And so what you'll see in this hurdler is she's in the lead, and there it is, right? Didn't occur when she was going over the hurdle. It occurred as she went into her eccentric phase and hit the hurdle itself. Tensile forces probably surpassed the amount of stressors that hamstring could hold, and as a result, she had a hamstring strain. So let's go with degrees of strain, because this becomes very important. I know for most this is common sense, but for those of you who never really graded a hamstring strain or a quad strain, let's go ahead and define those. First degree strain is very interesting, right? Because what we say with the first degree strain is, okay, there's trauma to less than 5% of the musculotendinous unit. However, we don't know this, right? We don't know this because we don't have an MRI. So what we see is that there are stretching of the fibers or damage to the myofibrils, okay? How do we know this? This is all great, and this is all very objective in nature. One way we know this is by strength testing or manual muscle testing. We see in a second degree, if we're looking at just differentials, okay? Usually, generally speaking, there's ecchymosis present, in other words, bleeding present. You get a more pronounced inflammatory response, so you actually might see some swelling, and then you actually have tearing of the actual muscle fibers. In a grade 1, there's stretching of the fibers, but there is actually no tearing of the fibers. In a second degree, there will absolutely be tearing in the muscle fibers. So that is a major differential between a first degree and a second degree, and it's one of the reasons that we tend to see this bleeding present in a strain. Last but not least would be a third degree, and you're hopeful that you never have this happen, but it's a complete rupturing of the muscle. And so that patient generally will have complete loss of function. There will be a defect, right? So if we're thinking about what we talked about on the first slide, there will be a defect, definitely without a doubt some swelling. And then in addition to that, there will be pain that obviously accompanies that pathology. Differentials, if I knew, number 1, there's stretching of fibers, but there's no tearing. In number 2, there's absolutely tearing of fibers. In number 3, there's a complete rupturing. In other words, all of the fibers have been torn, and that patient will not be able to function. They will not be able to do manual muscle testing or strength testing because the reality is they have complete loss of function. Third degrees, they take forever to heal depending on the muscle. Sometimes they require surgical intervention to kind of tack down the muscle that has been ruptured. It really just depends. But again, when we're working in this class, we really just want the differentials. What's the difference between a first and a second degree tear? Well, I would say there's stretching of the fibers in a first degree, but in the second degree, there's actual tearing of the muscle fibers themselves. So those are the degrees of strains. If I were to ask you, okay, grade this muscle strain, what would you say? How do you know? Well, one way you can tell there's ecchymosis present. So what you can say is it's probably not a first degree, right? You could maybe grade it based on the amount of ecchymosis that is present. And you could maybe say third degree, but then we don't see any defects. So maybe it's a second degree with a lot of ecchymosis. Why do I put this up here? Because when we grade a muscle strain, we should never allow the amount of ecchymosis to determine or to dictate our actual evaluation of a patient. What should drive that are the number of muscle fibers that are stretched or torn, the patient's function, right? Because in a third degree, they wouldn't have any function of that muscle potentially. So there are other objective factors that should drive our assessment of a patient. Next, we move on to tendinopathies. And most of you know most of the tendinopathies that occur within the actual lower extremity, but let's just go ahead and talk about it. Now, the term tendinopathy is very generic, and it's used to describe any tendon pathology, but it becomes important to differentiate between a tendinitis, a tendinosis, and a tenosynovitis because they absolutely are very different in nature. Okay, as indicated by the itis, tendinitis is an inflammation of the structures encased within the tendon's outer layering. Okay, so when we look at this picture here, what we are looking at really honestly is the anatomy of a healthy tendon, right? Ultimately, this is what we're kind of looking at. What we want to do is what we want to say is tendinitis, honestly, is inflammation of this piece of the tendon. In other words, it is inflammation of the structures encased within the tendon's outer layering. The tendon is surrounded by highly vascular peritoneum, and that is susceptible to inflammation. And if that becomes inflamed, then what we kind of can say is, okay, that's probably a part of the tendinitis as well. Tenosynovitis is inflammation of the synovial sheath surrounding the tendon. Okay, so when we look at the tendon, it would be inflammation of the synovial sheath of the tendon. So we're saying, okay, there's the tendon that potentially gets inflamed. There's the sheath that actually gets inflamed, right, with tenosynovitis. And then there's the last phase of that, which would be tendinosis. And tendinosis is actually like degeneration of the actual tendon itself. So in other words, there is actually wearing away of the tendon, and you will start to see it degenerate. And that's kind of where we're concerned, right? With tendinitis, okay, the tendon's inflamed, the tenosynovitis, the structure surrounding the tendon's inflamed. But with tendinosis, because either the tenosynovitis and the tendinitis have really just blown up. What you see is that inflammation from the tendinitis or tenosynovitis starts to eat away at the tendon. And that's a concern. And the reason it's a concern is because that's when we start to see tendinous ruptures, because that tendon is actually now compromised because it's less weak. There's less cellular matrix to it. And so if you have a patient with tendinosis, then you remove them from play because you're concerned that, in fact, they would actually suffer from a rupture. The other pathology that can occur to a tendon is what we call peritendinitis, and that is inflammation. Inflammation of the peritendon of the actual tendon itself, and so it will be inflammation of this piece right here. As you can see, the tendons are encased in this structure. So can you guys see that okay? Hopefully. So the tendons, right, they're encased in this peritendon. And so sometimes you can actually get inflammation of not the tendon itself, but the outlining of that. And so what are the signs and symptoms or the differential? It's kind of hard, right? Because ultimately what you will tend to see is that the patient's going to have pain. One thing that we tend to see with peritendon versus tendinitis is that with peritendon, the pain's more focal. With tendinitis, it's usually all over because it's in the actual tendon itself. So one of the major differences between peritendinitis and tendinitis itself is pain will be more focused with peritendinitis. Okay, so ultimately with tendinopathies, we have 3, maybe 4 different types. Tenosynovitis, which would be inflammation of the synovium surrounding the Achilles tendon itself. Tendinitis would be inflammation of the actual tendon. And then tendinosis would be degeneration, right? Now the inflammation's been sitting there so long that it's actually started to eat away at the cellular matrix of the tendon, making it weaker, making it more susceptible to rupture. And then last but not least would be peritendinitis, which would be inflammation of the actual case or thick tissue bundling that actual tendon itself. Remember differences between peritendinitis and tendinitis. Peritendinitis more focal, more local in nature. So our next step is degrees of tendinopathies. How do you kind of determine the type of tendinopathy or the degree? One way to do this, one way that clinicians have done this is with the first degree tendinopathy. What we tend to see is there's very slight dysfunction and the patient only has pain during activity. In other words, when they are not doing anything, they have absolutely no pain. They don't have pain after activity, just during the activity. In a grade 2 or a second degree, there's definitely a decrease in function, and that patient has pain mainly after the activity. And then last but not least would be a third degree. Third degree tendinopathy, they're in pain all the time, walking, sitting, sleeping, and they can't perform the activity like they normally would if they were healthy. So if we have differentials, really what we're looking at is when is the pain. If it's during activity, it's a first degree. If it's after activity, then it's second degree. If it's constantly, then it's a third degree. So those would be my differentials as I'm working with the patient and I'm assessing them. It would be a history question that I ask them, when do you experience pain? And let them describe it. Is it during? Is it after? Is it all the time? That will kind of help you grade the tendinopathy. Okay, moving into acute and chronic soft tissue injuries. The first type of pathology is a contusion. I'm assuming all of you know this by now, but if not, a contusion or a bruise, as some of you might call it, is a soft tissue injury. It always results from a direct blow unless you have some type of disease that kind of causes bruising. For the most part, it always occurs from a direct blow. What we tend to see is that those superficial capillaries become damaged, and as a result, there's bleeding that occurs, and the patient presents to you, and they look something like the patient on this slide, right? There's lots of ecchymosis. There might be raised skin. You might actually have some swelling, and so I've been describing contusions as it applies to soft tissue. However, you can absolutely have a bone contusion as well. The most common bone contusion that we tend to see is in the tibia. And generally we see that in soccer, and it's because it's really superficial, right? And it's very exposed. And so these can sometimes be more painful than a fracture. They can sometimes be more painful than a muscle strain because it's so superficial, and they can also take a lot longer to heal themselves. So a couple things that we want to do: we want to rule out a fracture, and then we also want to make sure there isn't any superficial nerve damage when we actually do have contusions that occur to either the soft tissue and or the bone. And then just quickly, we'll talk about this when we get to specific joints. How do we treat a contusion? The simple answer is to ice it. And then if it's to a soft tissue, once they are pain-free, to stretch it a little bit so that they don't lose their range of motion. And if they're participating, then we want to pad it. So we can kind of create a pad here so that they don't keep taking repeated blows to the soft tissue. Because if they do, then the next pathology that we have is heterotropic ossification. And heterotropic ossification, also known as myositis ossificans, is basically formation of bone within a muscle belly. And so what we'll see here is a surgical procedure. And what you can kind of see from this is that the patient actually has bone formation. And so the physician's actually going to go in and he's going to cut that bone out of the actual muscle. What we see with heterotropic ossification is what we see here, is this bone that has grown in between the actual muscle, and I believe this is a quad, this massive piece of bone. Well, how does that actually happen? It happens twofold. There are a few reasons why it happens. When a patient takes a blow, let's say to the femur, what we tend to see is that if there are repeated blows, that muscle and that fluid doesn't have enough time to heal itself. In other words, that fluid begins to get hard, that bone gets overstimulated by the microtraumas that are occurring, and what we tend to see is that bone starts to form in the middle of a muscle unit. And unfortunately, that's a bad thing because it reduces the muscle's ability to generate force in some sense. We see with heterotropic ossification is that it always occurs secondary to a traumatic injury. So in other words, a direct blow to the quadriceps or hamstring or any other muscle group, and then repetitive microtraumas after that. We see this most often in soccer, and that's just because of the kneeing and the kicking that occurs to the quadriceps muscle. But believe me, so it could also happen anywhere else. So hip adductor, and then the biceps brachii in boxing. So our concern is that if we don't care for this, in other words, if we have that massive bone formation like we do here, it can lead to compartment syndrome. In other words, that bone could start to compress on the nerves supplying that particular muscle, and then that can become an issue as well. But you can see the mass that they removed. Pretty massive. Okay, so if we look at it from an X-ray perspective, now what we can see here is this is kind of what heterotropic ossificans looks like. There's this development of bone that occurs, and as you take more microtraumas to the quad, then more bone starts to form. And again, that muscle can't generate force because it has to slide and glide against that bony formation in the quadriceps itself. All right, moving forward, we have bursitis. What is bursitis? I think you guys know, but if not, it's we have bursa in the knee. The bursa are fluid-filled sacs, and their major role is in protection of superficial bony structures, and they protect them from getting bumped, or they protect them from a lot of friction that occurs across them. There's many reasons and many functions for the bursae. What we see is that most often they are in the most superficial bones. So what we see here is a knee. So the patella is one area that has a bursa or mini bursae, and the elbow joint would as well. But bursitis is an inflammation, as the name implies, itis, inflammation of the bursa. It can be caused by several different things. What we most often see it being caused by is the traumatic force. Yes, it can occur by friction, increased stress, and a disease state. But in the athletic population or active population, most often it's us bumping up against something. So bumping our knee against something, bumping our elbow against something, and it causes that sac to kind of, in essence, explode or to blow up to protect that bone from fracturing. And so what we can see here is a massive bursitis. And how do we kind of treat that? Several different ways to do that. There's you can actually aspirate the knee or drain the knee. You can try wrapping an ACE wrap to control the swelling. Many ways to do that. So as I mentioned, there are many bursae in the body. These are the bursae in the lower limb. So we've got hip bursa, okay? Different ones. Most common one is the trochanteric bursa, and we'll talk about trochanteric bursitis when we get to the hip. In the actual Achilles or in the ankle, we also have what we call the retrocalcaneal and tendon calcaneal bursa. We'll talk about that more when we get to the foot. And then in the knee, man, at least 4. Why? It's so superficial, right? And lots of movement occurring, lots of friction that could occur with the quadriceps tendon, the patellar tendon, right? The semitendinosus or pes serine muscle group. And then last but not least, the biggest bursa, the prepatellar bursa, to protect the actual patella itself. So lots of bursae in the lower extremity, and we will dissect each of these when we get to that specific joint. And that brings me to joints and injuries to joints and compromise. So the first thing that I want to do is really just look at joint structure pathology. A joint really has many anatomical structures that make it up. And then the first thing is soft tissue, right? Soft tissue surrounds the joint, and by soft tissue, what I mean are muscles. We dissect away or we transect the soft tissues, then really what we have is a capsule. A capsule is formed by 2 bones, right? And then we have the ligaments that hold that capsule together, right? So let's take the knee. The MCL and the LCL really hold the distal femur to the proximal tibia, and that creates the tibial femoral joint. So where do we see soft tissue injuries occurring most often? In the lower extremity, in the ankle, and in the knee. And same thing with the joint injuries as well. So with sprains, what we can say about sprains, the joint is forced beyond its anatomical limits. So in other words, we basically apply this tensile force, right? And then there's a stretching and a tearing of the ligaments on the tensile side. But keep in mind that there's also a compressional injury that can occur to the opposite side of that. Remember, we said the ligaments make up a part of the capsule. And so we have to be very astute in our evaluation of a joint when the ligaments are involved, because the ligaments create the most stability about a joint. So a first-degree ligamentous sprain would present like similar to a strain. The ligament is stretched, but there is no tearing. What we see is a very firm endpoint in the ligament. You might have some pain, you might have some point tenderness, but this person is very functional, right? In the second-degree sprain, just like a strain, there's partial tearing of the ligaments. You get joint laxity or looseness when you stretch it. There's a soft, but there's still an infill. In other words, the ligament isn't ruptured. You're for sure going to get some moderate pain and swelling because you have tearing of fibers. And then last but not least would be a 3rd degree sprain. And this is when the ligament or ligaments plural is completely ruptured. So you're going to have a massive gross laxity at that particular joint. And this is a joint that you don't want to put into play, or you don't want them to be active on it, because ultimately you could actually create more gross joint laxity and instability. So let's take a look at this video here, hoping it'll work. Okay, maybe not. So what would you classify this ankle as? Just looking at it. Come to class and be prepared to tell me what grade of a ligamentous sprain you would give this particular pathology. I want you to be able to justify why you would grade it, what you've graded it. Okay guys, so this brings us to synovitis. And so sino, meaning synovium, and then itis meaning inflammation. And so it's basically the inflammation of a joint's capsule that often occurs secondary to the presence of existing inflammation in and around the joint. And it basically spreads to the actual synovial membrane, which is basically the lining of the joint. The patient might complain of fogginess or like looseness within the joint, and tends to hold it in a position that applies the least amount of stress and strain to the capsule. So in other words, when we have a synovitis, it's generally secondary to some sort of inflammatory condition, and that inflammatory condition could be irritation to the joint. It could be inflammation in the quadriceps muscle, which leaks down into or causes irritation of the actual synovial itself. And so what you tend to see is the patient kind of holding that joint in a semi-flex position or into a completely extended position. Synovitis is often associated with some type of comorbid condition, and the one condition that's most often associated with is degeneration of the joint or a degenerative joint disease. And so it's usually a secondary pathology that's associated with some sort of other knee pathology. The next pathology we'll talk about is a joint dislocation. As you know, a joint dislocation is a complete disassociation of the joint's articular surfaces, and usually there's an obvious deformity. And some have said this is an ankle dislocation, and others have said that this is actually a complete knee dislocation. Either way, we can tell that the joint is not in its resting position. So there's an obvious deformity, clearly. And you can also have an open dislocation. In other words, a compound fracture where the bones are actually protruding through themselves. So if you have open dislocation, then the concern obviously is for infection and for making sure that the patient doesn't go into shock. If you have a closed dislocation, the major issue is getting that joint back into its resting position. And in this case, this is an extreme dislocation where you're really concerned with neural supply. In other words, what nerves are being compromised. So we want to get that joint relocated as soon as possible. I will say this, that we, as athletic trainers at least, are not supposed to relocate a joint. However, if you are a physician's assistant, if you're a medical doctor, even a chiropractor, then the laws are different. You can by all means go ahead and relocate the patient. So that's a joint dislocation. Again, open joint dislocation. Major concern is whether or not they are actually going to get inflamed. Now we move on to pathologies involving the cartilage of a joint, and this is by far one of the major plaguing pathologies in the knee. We're starting to see it more often in a younger population, and so what we're going to be talking about now really is articular surface pathology, and pathologies that affect the joint's articular surface. In other words, the two surfaces that kind of move against one another. So the first thing we're going to talk about is hyaline cartilage. We know about hyaline cartilage is it's the lining of a bone's joint surface, and it can be acutely injured. It can be injured over time or with micro traumas. But this type of cartilage is really suited to withstand compressive and shearing forces across a joint, most often the knee, but we also see hyaline cartilage damage in the ankle as well. And as I mentioned, it can be acutely injured or can occur as a result of just aging or micro traumas. What we see with this is that if the hyaline cartilage is compromised, it's irreversible. In other words, there really isn't any surgical procedure, any exercise that we can do to kind of regenerate this hyaline cartilage. There are certain surgical techniques that have been used, but most of them have high failure rates. So what really are the signs and symptoms with a hyaline cartilage injury? What we see is that there's chronic diffuse joint pain, and the patient is very dysfunctional. In other words, if it's in the knee or in the ankle, which are really weight-bearing joint structures, what you see is that they really can't bear much weight, because that hyaline cartilage that was really good at withstanding those compressive forces is now really, truly, it's compromised. So what are some pathologies that can occur? The first one is an osteochondral lesion. We see with osteochondral lesions is that they result from trauma, but they can also result over time from gradual softening of the underlying bone. It can include the articular cartilage, and then also the cortical bone of the femur most often, but also the talus as well. And what we tend to see is there's defects in the articular cartilage that are present when you do an MRI and sometimes an X-ray. And so this becomes a concern because, again, it's major weight-bearing cartilage. So there are two different types of tears. There's a partial thickness lesion. With a partial thickness lesion, what we see is it involves the outer layering of the articular cartilage. So just the outer layers compromised. And then you have a full thickness lesion, which exposes the underlying bone and are almost always symptomatic. So what we can see is that, number one, you have this partial thickness tear. It involves the outer layer of the articular cartilage, but there's no damage to the bone itself, right? With a full thickness, you get articular cartilage damage. You also get compromise or wearing away or degeneration of the actual bone. And this is when your patient really starts to become symptomatic. So we can kind of see why hyaline cartilage tears really kind of unrepairable, because by the time they're symptomatic, it has not only gone through the hyaline cartilage, but it has also started to damage the bone itself. We also have this thing called juvenile osteochondritis. With juvenile osteochondritis, it's classified by bone maturity, and what we see is that it affects those with open growth plates. So in other words, we're describing an osteochondral defect that occurs to someone 15 years or younger as juvenile osteochondritis, because what we see in these individuals is that the actual growth plate is still open. What we see in those over the age of 15 is what we call adult osteochondritis dissecans, and commonly it results from some type of old juvenile lesion that you already had that maybe wasn't cared for. What we see in an OCD is that you tend to have some bony fragments that may or may not be loose within the joint, and we see this most often occurring at the talus, at the femur, distal femur most often, and sometimes in the patella as well, at least in the lower extremity. What we see is that it's one of the most common causes of knee pain in children between the ages of 10 and 15. Why? Because their bone is really soft and really porous, and it's also the time when they're really active, and also their growth plates are open. So osteochondral defects are defects that can occur to the articular cartilage and the bone. If it occurs to the bone, you may also have fragmented parts circulating throughout the knee, and that can cause problems as well. So when we look kind of at this MRI, what you can see is the beautiful femur here, really nice rounded femur, and then what you start to see here is probably what we would consider as a full thickness tear. So you have wearing away of the hyaline cartilage and then some degeneration of the actual femoral bone. This is a bad thing, right? Because what this means is eventually, if you keep applying stress, probably going to have a complete fracturing of this condyle here. So let's go with fractures. Different types of fractures can occur in the body. The first type of fracture that we have is what we call a non-union or a malunion fracture, and that there are major differences between the two different types of fractures that we're going to talk about. The first type of fracture that we're going to talk about is a non-union fracture. We look down here and we can see that this is a non-union fracture. In other words, it's an incomplete fracture healing. We define a non-union fracture really as a fracture that fails to heal within 9 months of the expected required time. So an example of that would be a fracture that is supposed to heal in 2 months, and in 11 months it still hasn't healed itself. That is a non-union fracture. There are definitely implications for this if you have a fracture that does not heal properly. When you apply stresses to that particular bone, possibility of a compound fracture is obviously increased. We also have a fracture type which is called a malunion fracture. These are healed fractures that leave the bone in a functionally unacceptable position. So in other words, it heals itself, but it doesn't heal itself in the correct position. You can see with this radius and ulna that fracture isn't aligned correctly. So what do we do with this? The bone is still kind of weak, and it cannot perform its function like it's supposed to. So physicians sometimes will go in and refracture and pin it down so that it heals in the right position. If I had to choose which fracture to be, I wouldn't want to be either of these, but I guess if I had to choose, at least with the malunion, the bones are healed, so you can apply more stressors across this joint than you would this one. The stats. What do we know about fractures? Nearly 8% of tibial stress fractures heal with malunion that results in a limb deformity. In other words, 8% of patients who suffer from a tibial fracture will not heal in the correct position. Well, that's a major issue when this is the major weight-bearing bone for the lower limb, so there's concern there. What we see is that between 2 and 10% of fractures of the tibia result in non-union. So there are some people whose fractures just never heal themselves at all. And again, that's a major issue too for the reason that I just mentioned. We also see is following surgery, to repair displaced hip fractures of the femoral neck. Okay, 10% of individuals develop a non-union. So after we repair a femoral neck fracture, they don't necessarily heal themselves. In other words, those bones don't heal themselves very well. So that's led to the internal fixation or use of screws to kind of hold that hip in place. But what it also means is that with the tibial non-unions and malunions, and same thing with the hip, is that these patients might suffer from leg length discrepancies because these bones just are not healing themselves in place. So we can see different types of either non-unions or malunion fractures and what the implications are for those. Definitely mass deformity if the bone heals in this direction. Biggest concern here is whether or not you can bear weight on the wrist in a non-union fracture. And one of the most common non-union fractures that we see is a fracture that occurs in the lower extremity to the base of the fifth. And we see, I mean, it takes sometimes 2 or 3 years for this bone to heal, and that's with surgical intervention. What we say is ultimately we really want to put the bone in a position to heal itself. And so most often when we know that there are bony sites that are susceptible to non or malunions, the physician will go in and just do an open reduction internal fixation. In other words, that physician is going to screw that base of the fifth down. Okay. I think this is our last section, is the section on bony abnormalities. These are just as important as bony fractures or dislocations or any other thing that can occur to the joint or the bodies. And so we have bony abnormalities. The first bony abnormality that we have is what's called an exostosis. And this is really as a result of growth of extraneous bone at the site of stress. What we learned in the first 2 slides of this lecture were that Wolff's law states that a bone remodels itself in response to forces placed on it or stressors placed on it. In other words, if you don't place a lot of stress, you really won't have bone growth. If you place too much stress, then you have a lot of bone growth. And either one of those is a really bad thing to have in a bony situation. So exostosis, growth of an extraneous bone, it can occur as a stress reaction to an injury or based on too much forces being applied to that particular bone. And what we tend to see, and what you see here, okay, or here, and then definitely in this toe here, is that bone develops as an exostosis or an outgrowth at the site of stress. And so it becomes very painful, and if it occurs in a joint, it will absolutely limit motion as well. So what's exostosis? Major growth of a bone in a high stress region. Most often you see an exostosis in the ankle joint, and then you also see it in the first ray, and that's because sometimes the first ray will rub up against, let's say, a tight shoe. An apophysitis, sometimes termed growing pain, as some people like to call it, is an inflammatory condition involving the bone's growth plate. And in the foot, we tend to see this most often in the posterior calcaneus, where the posterior hasn't, the calcaneus hasn't fused completely. And so what you tend to see in adolescence is that that growth plate represents the weak link along the bone. And so what we tend to see is if there are stressors being applied to it, that in fact that growth plate cannot seal itself. So why do I have this picture up here? Because this is an example of what we call a calcaneal apophysitis. In other words, this is the distal attachment for the Achilles tendon. If you can imagine that the gastrocs up here are really tight and they start to tug on this Achilles tendon in an adolescent, what you'll start to see is that Achilles tendon, if that growth plate isn't fused, will start to pull and tug away at that growth plate, and it might not heal itself, or it might irritate the apophysis, creating what we call an apophysitis. And so if we had to define it, inflammation, separation of a muscle and a bone, or a tendon and a bone. And then we also see this in individuals who grow very quickly. Their growth plates just cannot keep up with them. This is going to be very painful, specifically if it's at the calcaneus. Anytime they put on their shoes, anytime they go to cut or make a burst, it just becomes a very painful condition. So we'll talk about more how to manage that pathology when we get to the foot and the ankle. All right, injuries to the skin. Let's go with abrasion. And abrasion, for most of you, would say is like a strawberry. It's a wearing away of the superficial tissue of the skin. And we're not really concerned about much here except for infection, right? And so we can see here that if you don't care for an open wound, specifically a superficial abrasion, then it could wreak havoc. In other words, that patient could get a systemic infection. So we want to care for that. We want to clean it. Recommendation is antibacterial soap and warm water. And so that's how we're going to treat that. The next type of skin pathology that we have is what we call an incision or a laceration. And if we had to define what a laceration was, we kind of would just say it's basically like almost like a tearing of the skin in one direction. And some lacerations are going to be easy to care for. This maybe suturing. Well, others might be more difficult, right? This is a laceration to the actual carotid, so you'll have to control bleeding and worry about suturing later. And then there are some that might be warrant a referral to the ER, right, to remove the screws and then to clean it out and then to close it up. So this is a laceration. Most lacerations that are at least 2 centimeters deep require sutures. Any lacerations on the face refer for sutures, of course, because we want our patient's face to remain pretty if possible. A puncture wound. This is just one example of a puncture wound, but there have been others. You know, I tell the story that Dr. Gans was covering a javelin event, and a javelin went through someone's eye, clearly a puncture. So a puncture is something that pierces the skin. In this case, we have a pencil going through the cheek. But when you have a puncture wound, the big deal, the big rule of thumb is that if it's not obstructing the airway, you keep it in, and the major rule is to stabilize that, pad it with as much towels or shirts, and to stabilize that punctured object, and then to refer and have it removed at the ER. The avulsion, you might see this most often in sports, but the avulsion is where skin, right, has been removed or a tendon has been disrupted from its attachment site, muscle, whatever it might be. So with an avulsion, a little more difficult to care for. You have to reposition things, replace things so that they can heal themselves. So you just have to be very careful when you're dealing with an avulsion injury. In amputation, you hope this never happens, but you know what? It's happened right here in this office. Someone was using the paper cutter and got their distal interphalangeal joint or their finger cut. And so we had to actually refer. When you have an amputation, what you want to do is place the amputated body part in a sterile bag, and we'll put it on ice, and you want to send it to the ER with the patient ASAP, so that way they can hopefully reposition it and it becomes a viable joint for those particular patients. We have one more topic to cover, but before I do that, it's a complete transition. So we're done talking about nomenclature for the joints, the bones, the anatomy, and now what we're really going to talk about is nomenclature for neurovascular pathologies. These occur just as often as do muscular injuries, bone injuries, etc. In fact, sometimes they're concomitant injuries, and so it becomes important to also be able to speak the language. When we think about neurovascular and neurological pathologies, trauma to the nerves, arteries, and vein is more often a consequence of a specific pathology, generally joint dislocations, bony dislocations, compressive forces, and compartment syndromes. And so why are we concerned? Because if they are left untreated, you know, what we see most often is that vascular disruption can lead to the loss of an affected body part. So to me, these are the pathologies that are probably most important to assess when we're talking about nomenclatures and injury pathology. So a peripheral nerve injury. We think about this, what we're thinking about is entrapment injuries to the peripheral nerves. And so we're going to spend a lot of time on peripheral nerves in the lower extremity. In fact, you will be experts on the nerves that supply the lower extremity before you leave this class. They're most common in the ankle of the lower extremity, but the knee and the hip, don't forget about them as well, but most often it's the ankle because that's where most injuries occur to the lower extremity, secondary to the knee. Peripheral nerves located more distally from the spinal column have greater probability of regeneration than a lesion that occurs more proximal to the central nervous system. So that's kind of just like nerd information for you. So what do we see? The nerve becomes entrapped, usually entrapped because of some type of traumatic incident. And so what are the signs and symptoms associated with a peripheral nerve injury dysfunction? The big one is going to be paresthesia, so some type of neuropathy or neural dysfunction. And if that nerve is supplying a muscle, the muscle that it supplies may also, or muscle groups may also become weak. So it becomes important to not only know the nerves, but to also know which muscles they supply in the lower extremity. So let's take a look at the anatomy of the nerve. Here you have a nerve, and basically what you are looking at are all of the anatomical structures. And these anatomical structures become important when we talk about the grading of an actual nerve pathology. So superficially, what you have is the epineurium, and the epineurium is the most outer structure of the nerve. And then the next thing that you have to the nerve is the perineurium, which kind of houses the actual myelin sheath and the axon. So perineurium, then you have the myelin sheath, and then last but not least, the axon of the nerve. And these all kind of work together to kind of send motor and sensory information to the brain, and then to bring it back down to the periphery, where it can be interpreted as pain, as numbness and tingling, as whatever it is that your brain tells the body to interpret. So when we think about pathologies, when we think about neuropathologies, there are really three different types of neuropathologies that can occur. And as we move down the scale, the more severe the consequences are. So the first one that we have is a neuropraxia. In a neuropraxia, the nerve becomes compressed, and the injured anatomical structure really is the epineurium, the connective tissue, and the blood vessels. You get a little bit of myelin sheath stretch, but what we don't see is there's no compromise, there's no injury to the myelin sheath itself. There's just a little bit of stretch. Everything is intact. So the epineurium's intact. Let's go back here. The perineurium's intact. The myelin's intact. The axon is intact. So this patient might complain of numbness and tingling for a tad bit, but then eventually it will resolve itself. So that's a grade 1 neuropraxia nerve injury. A grade 2 is an axonomesis, and this is where the axon of the nerve actually gets disrupted, as does the myelin sheath, but the epineurium remains intact. So let's go back here. We said the axon gets disrupted. We've also said the myelin sheath gets disrupted, but ultimately the anatomical structure kind of holding that nerve together is still intact, and it contains that connective tissue. So we're still okay. Patients that suffer from an axonomesis have a complete disruption of neural signs and symptoms, and additionally what we see is that they complain of signs and symptoms for a lot longer. What we see most often if we're doing a differential between an axonomesis and a neuropraxia is that for the most part the symptoms are the same, except for the duration of symptoms is generally a lot longer. And so we just don't know how long it takes to resolve those signs and symptoms, but we do know that the signs and symptoms last a lot longer. The last and definitely the most catastrophic of neuropathologies is what we call a neuromesis. A neuromesis is a complete disruption of the nerve. It's the most severe form of peripheral nerve injury. And then the prognosis for the return of normal innervation, right, normal supply to that particular muscle group is very poor. The injury occurs under extremely high forces, and usually entails some type of concurrent injury to bones, ligaments, and tendons, right? So we can imagine like a complete knee dislocation. You have the ACL rupture, you have maybe some MCL and meniscus. In addition to that knee dislocation, it impinged upon some of the neurovascular structures that supply the knee. In that case, you might have a neuromesis. We see is that many times a nerve graft is required to repair the function to the extremity because the nerve has been so damaged. So what we can see again, just like with a strain or a sprain, is there are grades of neural injury, neuropraxia being most mild, axonomesis being second degree, and a neuromesis being a third degree. Ideally, what you don't want is a neuromesis, right? Because there's such a poor prognosis for neural regeneration. Axonomesis, you'll get your function back, but it just will take a little bit longer than a neuropraxia. Big deals here to remember is that there are different anatomical structures that are involved. In a neuropraxia, epineurium, myelin sheath, everything's intact. There's a bit of a stretch, but with an exon-mesis, what you get is the axon disrupted, you get the myelin sheath being disrupted. However, that thick connective tissue of the epineurium is still intact, and so that's why we can see this neuroregeneration and restoration of signs and symptoms. And last but not least, with our neurotmesis, everything's disrupted, and therefore you don't get regeneration. Sometimes you have to actually do a neural graft. That's the end of this lecture. Very, very long, but I'm really hoping that when you come into class, we're all on the same page. So when I'm speaking the language, you'd be able to speak it back. Thank you so much for your time and for listening to this online lecture. I'll see you in class.